this special session on psychological health issues. You will hear about this project and about the findings of this project. And we have Markus González Beilfuss with us. He is a professor of, I think, is this true, of constitutional law? Is this? I wasn't sure. No, I wasn't sure. I put it there. Of constitutional law of the University of Barcelona. But of course, you know, he has done many projects. He has taught in New York and at universities. He has advised the Spanish government, etc., etc. So I cut it short, but he is an excellent person. We are very glad to have you here. And we have Mar Ramos. She is a psychiatrist and from the transcultural psychiatry and working in a hospital, the Vall d'Hebron in Barcelona. Yeah? So there was also a third person mentioned, but you said she is, we knew she is pregnant and she doesn't feel well, so she couldn't come, but we have the two important people here, so this is not a problem. And then, after that, we will have a short discussion, a panel discussion with people from other parts, you know, not only from Barcelona, but we will have a discussion with Federica Marengo and Patrick Hauvuy. They are working and coordinator and responsible for a national, in France, for a national organization called Dispositif National and responsible. You will tell us what it is exactly. Then we have Evelyn Probst, long-standing expert, you know, here in Austria, and we have Norbert Ceipek, a very special person. You know, he was responsible for in Vienna for many years for the so-called Drehscheibe, which is a center for unaccompanied and smuggled children and minors. And he, at that time already, he started to tell Bulgaria and other countries what they would have to do. And now he's himself in Bulgaria and responsible for projects and shelters. Yeah, that's it, and you have the floor.
Okay. So thank you very much, Helga, for giving us the opportunity to be here and to share with you some of the results of a European-funded project. And thank you for staying here today at 4 o'clock with this sunny day on Friday evening. So it's incredible that you are here. We were talking with Mar how to do it, that you don't fall asleep, that it's more interactive. We will try to do it. The idea is not to talk about everything, but to just talk about some of the activities that we have done within this project. And the aim would be, this project is going to end this year, at the end of this year. We will have the final conference 30th of November in Barcelona, so you are more than invited to attend this conference. And there we will have also more time, workshops, etc., to discuss on all these issues. No? So the starting point of the project was very clear. We, academia, but also NGOs and some practitioners and policemen, etc., that there is a gap between psychological health impact and how to tackle the issue. No? We know that most of the victims, of course not all of the victims, have a psychological health impact that is different from person to person, but we don't know exactly what this is and how to tackle this in order to help the victim and also in order not to have a negative impact in the interaction with the victim. No? This was clear, and then the idea was, okay, how to try to make this gap a little gap, and so by increasing knowledge and then to develop some tools for a better intervention. It's a 2-year project, and we managed to build a consortium with 12 partners from 5 different countries, European countries. Here you have them. We have on one side universities, so research perspective, Barcelona University and Tilburg University. Then we had, and this I think it's important, the idea of having also as partners public institutions on board. We managed to have the Catalan police. We tried with the Dutch police, but at the final end it was not possible. And then the third group of partners are NGOs. In this case, Spanish NGOs, the 3 Spanish NGOs that have direct contact with victims and shelters, etc., and fields in the Netherlands. And then the same with not partners, but support partners. No? So in general, in total, there's 12 partners. I think this idea of trying to bring together in a research project these different perspectives has been very interesting. It's also difficult. Our perspectives are different. Our how we work, it's different. So coordination for me has been sometimes difficult, but I think it is in this kind of roundtable, it's important to say, it has a lot of advantages. And it's without this consortium, I think it's impossible to try to increase the knowledge on this and then to develop practical tools in order to better the situation. So these were the main 2 objectives, to increase the knowledge on the psychological health victims. I have to say the project is focused only on THB for sexual exploitation and female sexual exploitation. I know THB is much broader and we always blame on this very focused approach, unrealistic approach, but when you have to do research, you have to only tackle 1 or 2 perspectives. So here it's only psychological health impact caused by THB for sexual exploitation with female victims. And the idea was to increase the knowledge and then from this new knowledge, to develop some practical tools to improve and optimize the attention provided by the stakeholders. NGOs, but also judges, prosecutors, police, etc. In order to do this, we of course had different work packages. I'm not going to get into detail. Today, what we're going to present here is more related with the second work package, so this increasing knowledge. How have we done this? Basically through 5 activities. The first one was interviews with survivors. We're going to talk about this because here we developed, I think, interesting tools. The second, focus groups and interviews with experts. The third, the psychiatric assessment of survivors, and this is something that Mar has done, so she will focus on this. And then file studies of some criminal proceedings regarding this, and file size also of immigration permits, residence permits. So the idea was in this 2 kind of activities to show, okay, which was the impact, the psychological impact of the victims within these trials and files, and which impact has this in the implementation of the legal rules. And then we have something related to state obligations and then the development of the tools. But again, what we are going to focus is today on only 2 of these activities. If you have some questions, maybe you can afterwards, I can explain you other activities. But mainly these 2, the interviews with the survivors and the psychiatric assessment of victims. I will focus on the first thing. The first was this interviews with THB survivors. Here, of course, the objective was to know more about the psychological health impact, because there are, of course, some researches on this, although here there are important methodological problems. What we did here, and I think this was the original approach, was to do these interviews focus not on the trafficking experience only, but on the life histories of the victims. We thought that it was very important to understand not the final trafficking exploitation process, which is of course vast consequences, but the whole life histories of these people. And then what we did is to tried to interview 30 victims in Spain, 30 in the Netherlands, from different origins. So we focused on 3 groups: victims from Eastern European countries, victims from mostly Nigeria, and in the case of Spain, victims of South America. And of course, there were some, of course, ethical and also data-related problems. But here we were very strict, and we did all interviews with, or through, I would say, the NGOs. So interviewers were NGO members that work and had contact with the victims, not researchers, not other people that may had a negative impact. So this was important. But of course, security protocols, data protection, this is highly secured, everything. So there we had some protocols, and well, I think there we didn't have problems. But we had to develop a methodology in order to just to say, okay, we would like to know this life history, you know? And we have created a new tool based on this life history calendar with different components. And this is something that in our workshop in November, we would like also to talk about how and to show it with experts and to, I would say, I'm not a psychologist, I'm a lawyer, so I'm not an expert on this, but I can tell you that the NGOs that participated with us, they were at the very beginning a little bit skeptical about this. Again, a new interview, what's this? After doing this, they were really happy. Now we understand lots of things, going back to the past of these people. And of course, with the training before the interviews, with interviewers, how to implement this protocol. I'm not going to explain all the main findings. That will take us more than 1 hour, just to show you some of the results that for us were important. No? Because it was a life history, we started from the very beginning. We started before birth of the people. And here, for example, we found out things like the abuse suffered by the parents of the victims. And here you see that in an important percentage of cases, violence or abuse affected also the parents of the victims. Early childhood. Here we found out that the relation between parents, a conflicting relationship, 42%. Traumatic events in this first, from 0 to 4 years. You can see here in 26 of the cases, yes, no? Traumatic memories related with death of beloved ones or violence. Childhood from 4 to 12. Here again, we have lots of results, but here just to mention a couple of things. Change of household between these years. In 46% of the cases, yes, change of childhood. Did the victim suffer from violence in this period? 72% of the cases, yes. Which kind of violence? Physical violence, but also sexual violence in a big amount of cases. Was this violence sporadic or continuous? 93% of the cases it was continuous. So violence is something that has been in the real present life of these people from the very beginning in their life experiences. Which symptoms during this here? We had post-traumatic disorders, anxiety symptoms. So this, again, this was really explained by them as something that started in their early childhood. And the adolescence, again, change of household, yes, 65% of the cases. The first sexual intercourse of these people, in more than half of the cases, unwanted first sexual intercourse. Did you suffer from violence in this early childhood? 83% of the cases, yes, we did. Which kind of physical violence, sexual violence? Was this violence sporadic or continuous? 72% continuous. Again, this idea of everything started very, very early. Main symptoms, again, post-traumatic anxiety symptoms, this also was detected before. No? Although, did you get any support? In the 80% of the cases, no. What we say, what we explain is that we had this, but did we have any kind of support during these ages? No. And then, of course, we had also lots of questions regarding more the trafficking, sexual exploitation experience. No, I'm not going to get here into the details, but the use of violence, although we know that in some cases is not so present, in the case of Nigerian women, for example, but in our sample it was very important. Or relationship with a trafficker, in some cases they had. So, which is the important message I would just try to tell you, that this life history reflects multiple victimization experiences. No? So it's not only the question of the final trafficking. Trafficking in most of cases is also a way of getting out of a real, very traumatic life before the trafficking experience. This experience of physical, psychological, sexual violence that started before, and therefore there's accumulations of symptoms and a lack of support during a long period of time. So therefore our concept, this is not new, but we're working on, is this idea of the complex trauma, something that tries to say it's not only PTSD that is related to the trafficking situation, it's something that started much before and that during lots of years had any kind of psychological support. So this would be very briefly one of the activities. Then I give now the floor to Mar, so she can explain the second activity.
Thank you. Thank you, first of all, to invite us also, because as I've been here all the day, like Markus, and we are really in a different field. I hope that you will enjoy our presentations. If it's anything very technical or like I'm not giving the message properly, just stop me, because I'm a psychiatrist. I'm a clinician. I'm not academical. I work in a super huge hospital. It's the biggest in Barcelona. It's the national health system. It's a public hospital. So I'm used to deal with lots of patients and to speak in congresses where my colleagues are psychiatrists. So maybe my speech is a little bit technical. Just stop me if it is too much. So in this journey that Markus was explaining about the PHIT project, we crossed by together, and we get to, because they are in academics more than in the clinical field, but we met each other, and then they asked for us, for the transcultural psychiatry unit, if we could collaborate with the project, because they wanted to evaluate the victims, have a forensic psychiatric clinical evaluation. And then they knew that all the victims were from different cultural origins. So this was already a very challenging situation. So not any psychiatrist would be able or trained to do it in the best way. Not because they don't want to, it's because they need some extra training. So we decided to say, okay, we will collaborate. It's really an interesting project. And I'm going to give you the results. Okay, easy. So I will have to watch a little bit because I don't remember all of the slides. So before any collaboration, even if it was a clinical collaboration, clinical assessment, we always, because of our biomedical brain, we needed to do a very intensive research before. So what have been published, what do we know about the phenomenon? And what we knew and what we found, even if there is not much literature, talking from the scientist's point of view, like articles, scientist studies published, we found that, yes, the traffic of human beings has serious repercussions on health, mental health also. And this is the main problem that we needed to evaluate because of the violent situations and the coercion and all the situations they've been through. They have consequences on their physical and mental health. Like Markus was saying, it's a long road usually of many, many, many violent situations, not only the trafficking. So what we found is that there are not many studies. That's what I want to repeat, because really to find studies being done in Europe are kind of old, like some of them more than 10 years ago, with small samples. Most of the studies we have are done in the US or maybe UK or Canada, other contexts, which I don't mean they're bad, good, they're just different. So we needed to know what's going on in Europe. How do we face this situation? But we didn't find many of them. So what we had, according to what has been published for the last 30 years, what we know is that most of the, sorry, I'm too tall for this micro. Oh, wait. According to, I'm a very Spanish tall person. Maybe I can use the normal, because it's really getting hard to me to move. Yes. Hola. Gracias. Really, I'm so tall, I'm sorry. They keep talking to me in German. A ver. So, according to what we have, but not in Spain and not in Europe, we have the depressive disorders, anxiety disorders, and post-traumatic stress disorder. Here comes the technical part. I will try to clarify it. So that's what we knew. So we wanted to know, we wanted to help out also. So what is been published all around the world from those little studies that they are, is it going to be the same in Spain? Is it going to be the same for our collective, for our women? And in Europe, we say Spain because we've been working in Barcelona. The other teams, they couldn't make it, not the Netherlands, sorry, and not other countries. So we decided to make an assessment, evaluation, trying to just tackle, trace, if we do have mental disorders in this group of women affected by violence. And we decided also to check it on the first 6 months after they went out of the network, because it wanted to be like the first impact. Like if we had more time or more money, we would like to make it on 12 months, 18 months, to follow up. That's what we call longitudinal. But from this time, we just have this part. So we decided to do a semi-structured interview, which is typical in medicine. Yeah, there's many things you have to ask, yes or yes, and then you use some questionnaires that are validated for the disorders you're tracing. I'm not going to go on the technical part, but it's very serious, precise, the way it should be. Going to go lightly to the results. So the sample was 30 women. It was really hard for us to get to those 30 women, but without the NGOs, it wouldn't have been possible. So our coordination was between the PHIT coordinators and the NGOs, because this is a collective, this is a group very complicated to reach. They don't trust nobody, they don't like to talk about their story, and they especially don't trust psychiatrists if they know what it is, a psychiatrist, because sometimes they have different conceptions of psychiatry. So for us, the first very good impact of the story is the collaboration that we created, because the participation of the women was volunteer. They could make it or not. It was offered through the NGOs. They said there is this option. You can go and see the doctor in the hospital. And it was for the target, it was all the women that have arrived to the NGOs. Do not have a bias. You know, like bias is bias in any field. Like in medicine, it's very important, because if you are testing something, you have to go to general population. Otherwise, you would magnify the results. If you just analyze those women that they do seek for help or they do ask for it, then you will have more numbers. So we wanted to get to all the women that they were sheltered and offer the possibility. So, and then we put the target of 30 because it was really hard to get them and we didn't have more time. So for those 30 women that we assess, we evaluate, again, that 72% were from Africa. And those from Africa, most of them from Nigeria. This is what happens in Barcelona, but I guess it's the reality in many countries in Europe. Maybe other countries you don't have from Latin America, because we have a special link and special relationship. So I'll talk about Latin America later on. But most of the victims are from Africa. I think it's small, but Nigeria is the most represented country, and the rest of them, they rarely get distributed from the same numbers. Women, when we evaluate the women on those 6 first months, the age was 26.6, the average. Some of them were minors. We also collaborated with the government, with the shelter institutions that have minors. And the eldest victim was 47. So when we evaluated them, we assessed them, the average months they have left their country was 20 months ago. This is very important also for the life history that Markus was explaining. We were trying to find if there is a relation with those women being very long trips, very dangerous, very risky. I cannot go further on the details, but we will publish this article, so I will give you the link. The point is that for Latin American women, for example, this is not a long trip. Usually it's a fast trip, but not a honest one. They don't know exactly where they're going, what they're going to do, but it's a fast one. They just leave their country with a normal flight, with a visa, tourist visa, and they get directly to the trafficking situation. For the African women, as you all know, you know the situation, usually it's a very long, complicated story. So we wanted to trace if there is a relation of long trips and complicated, and there is, but I don't have time to go to further details. That's what I was saying, no? About the variability, it depending on the country of origin. For those women that we evaluated, they had been 9 months, 9.6 months in Spain before going out of the net. This is something we also wanted to analyze, like in a typical classical hypothesis in science. So if the more of the months is being exploded, it will have a bigger impact. So, but we need a bigger sample for most of the studies. We cannot reach all the targets we wanted, but we did collect this data. So, at the period of the mental health evaluation, the victims have been out of the net for almost 2 months. So it was like we did manage to have like a fast track, we call it. This is not easy. Now I'm going to talk about national health system. We have big waiting list. We have many patients in the hospital, so we could not collaborate with the normal waiting list process. So we said, no, we're going to have a special issue with this and a fast track, so we can see the women fast if they want to come. When the NGOs, they propose it to them. So we can catch them and analyze them during the 6 first months that they are out of the net. So this is pure statistics, medical ones, but statistics. What we found is not different from all the other state of art that we review. So we didn't expect it would be different. We didn't expect that they have many more disorders than they found in the UK or the US, but we needed to know what's going on here and now. So in this sample from these women, 60% of them, they did present mental health disorder. So not only psychological impact, a typified and feasible diagnosed mental health disorder. This is the technical part, but I'll kind of explain for it. Okay, so the most frequent disorders were already the ones that we have seen in the literature also. Nothing different. The victims here are not different like victims in the US. But yes, what we know is that for our diagnosis also, the most prevalent one, the most present one, was a general anxiety disorder, which maybe is not so impressing like the PTSD, post-traumatic stress disorder. So I'm going to use it now short. PTSD is very strong, is a very hard diagnosis, it's really a big mental health problem, and it's really very obvious, not very obvious, but anyone in a way can analyze and see that this person is really going through a very bad situation. What happens with general anxiety disorder is maybe not so obvious, but it really gives a very bad quality of life for women or anyone suffering from it. And also we had depressive disorders and panic disorder. To summarize, all the disorders we found, on those 60% that they had pathology, there was 40% that they had no psychiatric impact, at least of those 6 first months when they were evaluated. So for the victims that they did have pathology, 91% were, because all of those belong to the same category in the classification of psychiatric disorders. All of them are anxiety disorders. Fortunately, we didn't find other disorders that they could be really bad also, but because maybe the sample was small. This is always about science. If you sample small, your results are not interesting. But we're talking about clinics now. Also, just I didn't say at the very beginning, but within this collaboration, it was not only just to assess, we're following up these women. We're giving them attention, psychological, psychiatrical, we're collaborating in the medical way. So we had, the general anxiety disorder was really, really very present in these women. So when you have a GAD, your life is really miserable. You don't sleep, you're very irritated all the time, you're fatigué, sorry, this is French, fatigue, you're tired, you don't concentrate, you have memory problems, you have attention problems. Sometimes you have some phobias, like you feel you cannot do some things in the street, take the elevator, many things mixing in an anxiety disorder. And many of the women, because of the cultural issues, I'll go farther now, they don't recognize these symptoms. They don't think those are problems that they can be solved or treated. And I'm not going yet to the voodoo story. If we go to the Nigerian collective, then it's much more complicated. But let's just talk about the Latin ones, which is we have a common background, we speak the same language, we colonize them, so we're supposed to be able to communicate. Even for the Latin victims, it was complicated to identify that this is going on in me, and this is something it can be cured, or we have to deal with it. So just not to minimize, because sometimes in psychiatry, if the diagnosis is not so strong, like schizophrenia or bipolar disorder, we tend, or some people tend to minimize the impact of mental health problems. And those are the same. They are very impairing in terms of impairment. Most of women also, not most of them, but a third of them had 2 diagnoses or 3, so accumulating. Well, that's a long one. I will just summarize. Okay, so there was a relation, clear relation. So those victims who have met diagnostic criteria, they have spent more months in Spain when we evaluated. So we had the hypothesis like, okay, the more you are exposed, the more you will have these problems. But this is basic in anxiety problems. It comes from any field. Like the more you are under stress, the more you have been under life events, adverse life events, there is more risk for you to develop any kind of anxiety problem. So also, when we evaluated them, most of the diagnoses accumulated in those victims they had just recently left the net. So this is something that it makes us think about the future. So how can we help somehow? If we know that at the very beginning, from the NGOs, to be conscious also about this. So maybe we should think about having psychological support or psychological interventions in the sheltering programs. This is an idea, okay? And about PTSD, I'm gonna go fast because I'm taking long. Okay. So the time factor was, yes, related to why? Because there is an accumulation of stressors and risk factors for mental health. As we said, as Markus said, the traumas are multiple and along the way. So it's like some up and up and up and more. So as human beings, we have a capacity of resilience. Yeah, we have capacity to cope with things, or we have been distinguished already. But the story is like, yes, if we're forcing the system, it's going to be more complicated. If I accumulate stressors and stressors, it's going to be hard for me. And for us, at least in our sample, different from the samples we had evaluated in the literature, we found, as I told you, lots of diagnoses related to general anxiety disorder. So as I was telling you, it might not be so clear one, like in the movies. Everybody has seen any movie from PTSD, like victims of Vietnam, or like related to wars, for example. That diagnosis is kind of easy or clear. This person is under PTSD. He's having flashbacks, he's having nightmares, he's repeating the story. But for general anxiety, it's not that easy, so we have to be aware. So this is going very technical. I'm just going to talk about, we have two different ways of classifying mental disorders, or we follow the DSM, which is Diagnosed Mental System, this is American system, or we can follow the ICD, which comes from the WHO, from the World Health Organization. So from the PTSD American model, which is very based on big wars, on big impact, it's based on one trauma, one PTSD. But there is a big, what would I say in English, knowledge in the scientific community that it should be another one, because there are many, many persons going through not one trauma, not one Vietnam War, going through many, many multiple accumulated trauma. So it's not that the Europeans were more cool, yes, but the WHO decided that it has to be different. There is something going on. So now I'm happy that in June this year, the ICD-11 has been published. So in the ICD classification, you have PTSD, standard, and complex PTSD. So I deeply recommend you that you download it, you go to the WHO, and you put PTSD, and you find it in different languages also. So this classification is already official, and it opens for us more diagnostic fields. And why is it important to diagnose? Because if we don't diagnose, we don't treat. If we don't treat, we don't help. So if we don't help these women, they keep on suffering and going in a very bad situation. So this is just the very technical part, but if you can, please download it and check it, because it's really, really very clear. How is it going to be to classify it? Just a tip about the differences, okay? This is classical PTSD. The main core, they call the core symptoms, which is sense of threat, permanent sense of threat, avoidance behaviors. I try to avoid those things that they remind me, which it really affects my daily life. I have many avoidance behaviors, and re-experiencing. Re-experiencing the traumatic situation could be through flashbacks, images they come fast to my brain, or nightmares, repeated nightmares about this situation. This is the core of PTSD. So in complex PTSD, this is the same, it should be there, always re-experiencing avoidance and sense of threat. But there are three very big issues going on complex PTSD, which is what it's really there on these victims, on these people affected by it, that they develop, they do have like interpersonal disturbances. They have complex interpersonal relations. It's hard for them to really get related. They don't trust. It's very complicated. They have a very negative self-concept, self-image, self-concept, self-esteem, all of it. And they have what they call, it's an affect dysregulation, a mood dysregulation. So it's not a mood disorder, a clear one, that you're depressed or you're maniac, no. But it's really hard to get the mood compensated. So try to imagine how to live when you are just going through all of this. Not only the trauma and the re-experiencing, so you don't trust nobody. You sometimes have risky relations because you have interpersonal disturbances. So sometimes it's hard for us to understand why they don't, for example, protect themselves more. No, like from NGOs. Like they tell them, you were talking about media. No, like don't post nothing. Don't say nothing on Facebook where you are because you're being sheltered. I'm giving you an example. No, so nobody has to know where you are, where you live, privacy. And they have this lack of, sometimes, the complex ones, this lack of feeling this is dangerous because they're really affected about those things. So we have many of the girls that they might meet someone in the metro station because they contact them. I'm giving you real examples. And then they don't say for the NGO, of course, but they, after you talk to them and say, didn't you think that would be risky or it could be a problem? And they don't say no, because they've been years and years exposed. So their dysregulation sometimes make them hard to analyze what is risky, what is not risky, what can I trust, what can I not trust. Okay. So that's, I'm not going to go deeper in this. This you can find, this is the WHO, the OMS. It's very clear. If you want to check it, I think for those people really working in the NGOs or working in the field, it's nice to have to read it. So to have it clear, what do they talk about when they say complex PTSD? Because here is very small, I cannot explain for you. But they have these difficulties, regulating emotions, difficulties in relationships, belief systems affected because too many loss of faith and self-esteem, the flashbacks, the avoidance, everything. This is normal. The hyperarousal, this is a technical word of being on fear, like you are always like activated, like something wrong is going to happen. One thing very important, I'm going to the cultural part now, the somatic distress. Many of the victims, they come from different cultural backgrounds, and most of the psychological impairment and stress goes through body expression of it. They somatize a lot. Somatization is the word for my anxiety is not going on a psychological way, it's going through my body, which is headaches, stomach aches, back pain, and the more cultural it gets a situation, the more strange might be the aches. So we have to be trained about this. Like, yes, they can complain about many different aches in their body, and most of the time this is just somatization. It's anxiety going out from the body. And then many altered of conscious, that's dissociation, amnesia, this is deep also. I'm gonna go past this. This is pure psychiatry, but yes, it will affect, and I will tell the report. So, to get to the point. So what we think after this experience and after being working clinically with the women, that they do have serious effect on their physical and mental health. And for their recovery, they must have an adequate diagnosis and specific treatment. We need to work on it. It's a mental health, but health issue. If we take them to the doctor to check any kind of infectious disease, any kind of diabetic, heart problem, yes, mental health is health. So they have right to have a proper mental health also. So they have the right and they need to be attended on this. What's the problem? What's one of the big problems we know in transcultural psychiatry in general, not only with victims of traffic, is that there is a big stigma in many collectives, many groups, ethnical groups, towards mental pathology, towards mental diagnosis. So they don't want to come. So we need to work on that. So we need to work in education, information, and so it will be easier. What we found also in our experience, that this stigma is not only in the victims. This stigma and some kind of distrust is also many times in the non-health professionals who care for the victim, in the NGOs, in the police system. Like, nobody wants to psychiatrize or stigmatize, but by doing this, we're not helping them. We're just making it more complicated and making it longer. So this connection between the NGOs, it helped us so much to diminish this stigma. So we could reach the women. They could trust and come and get visit and just get evaluated. So what we think, that there should be early interventions and refers to mental health care facilities, because thereby we will reduce the burden of disease accumulated in anxiety disorders, and thus facilitate the process of psychological insertion. It's very complicated to insert someone psychologically, socially, if it's under really a big stress, anxiety, or any of the disorders. So we should promote this by decreasing and healing anxiety and all the disorders also. That would facilitate interventions that we do from other fields and promote mechanisms of resilience and psychological well-being. So that all those mechanisms, they wouldn't work if there is an active psychopathology and we don't treat it. When I mean treatment, I don't mean just psychiatric medicine pill treatment. I mean psychology, I mean psychiatry, I mean all the mental health system. And because of our group, it's very culturally diverse. So yes, I think we should have culturally sensitive services of mental health. This is going to my field now, to my colleagues. We should be trained because it's really complicated. It's not easy. Most of the women or transcultural patients, they just don't sit and go to the doctor and say, I'm having anxiety. No, they don't. Most of the Spanish patients either. But also in the cultural background, it's very complicated, so we need to help them to connect What is anxiety? Why is this happening? But we need to be trained for that also. I mean, the professionals. And we need to be prepared. We need to have units that they are competent culturally. What I'm talking about is because in Spain we have big lacks of, for example, we don't have translators. We don't have cultural mediators in the hospitals. So sometimes we cannot communicate with them because of cultural and linguistic problem. And so I do think it should be a training between the professionals. Just the last one, or two last ones. On my opinion, from my field, not trying to tell to the others what they should do, because I'm not a police, I'm not a judge, I'm not the DA, but I think it's vital to take into account the impact of psychiatric clinic on the victim's statement, because during the police investigation and during the judicial process, because since trauma, stress, and psychological shock exert a great influence on the accuracy of the statement. So if I'm trying to get a report, I'm in the police department, and the woman is under PTSD, for example, it's normal that her narrative, her story, is full of empty lacks. And sometimes it's refilled. This is normal. This is called fabulation. So it doesn't mean she's lying. It means that she doesn't remember at that precise moment. So maybe we should just wait a little bit or help out by having psychological support. So, but not just trying to get this information in a moment that the person is not able to give it. And also, like, therefore, it is essential that police and the judges take into account the psychological state of the woman and know how to contextualize this testimony to better interpret the statement and extract all the valuable information and data provided by the victim. So maybe there should be more than one assessment at police department, for example, or 2 or 3. Or maybe, ideally, we should work multidisciplinary, and then we should rely on each other and get to the forensic evaluation and say, no, maybe that's not the moment, maybe wait, can you wait 1 month, for example, and then we re-evaluate and you can do your assessment, legal one. But this is not working yet, at least not in Spain. We need to make it work. Well, I don't know about your countries, but in Spain there is not real connection between health system and judicial system, and I guess in many countries. So, last one. I believe, and from mental health perspective, we need to recognize the victim status. They need to be recognized as victims. Otherwise, it's very complicated for them to heal, recover. Recognizing the psychological consequence of violence and trauma in the victims is necessary so that they can continue with their recovery process. Like any victim. Unfortunately, in Spain, we have big experience of terrorism victims, unfortunately. So the first step is to recognize them as a victim. And after we start working. So in this case, they're not recognized as victims. So how are they gonna heal mentally? How are they gonna recover if they are not recognized? And we need to work on restore dignity, recognize the damage suffered, so we can strengthen their identity as survivors. So we need to start talking about them as survivors, not as victims. I'm talking about mental health position, okay? I'm just on the other side. So all this is necessary so that they can move on with their lives despite the drama they have gone through. So there is a life after this story, but we need sometimes to help out, so to help them to start moving on. And one of the steps really is basic, is this one. We're not gonna talk about victims anymore. We're gonna talk about survivors. And that's all.
No, thank you. Just, we are short of time, but I think only this research is so interesting that it would justify the whole project for me. But I mentioned before that our main aim was to create new knowledge, or better knowledge, and to try to implement this in very concrete tools. And just to give you some brief examples of this that we're working on this. Unfortunately, the project is only a 2 years project. It ends in October and December, so we have no time to do everything. But at least we started some things, and we have, I think, some ideas. First of all, for example, to have a new review or a new version or more concrete version of the indicators of when in the identification process, there are some indicators of trafficking. When it comes to psychological health impact, there's the concept of post-traumatic stress disorder. That's it. After this, the idea is to develop this, to get into the details in this identification criteria. A different thing would be related with security protocols for victims. No? Participating NGOs talk to us, we have security problems. The victims or survivors have problems, and we also, so we need some guidelines because, as you mentioned, most of the victims do not realize that maybe there may be problems, and so we are developing some guidelines, security guidelines for them and for the NGOs that are participating. Then, of course, training for judges and police officers that participate in the trials or participate in the migration files, no? Just to understand how to interpret these narratives of survivors. No? Then we have different activities with videos and training with them. And also one very concrete aspect is in the trials, in the criminal trials in Spain, till now it was not always the case that, for example, the prosecutors ask for a forensic report that is brought to in the proceeding and to the judge. When this happens, and this happened in some of the files that we saw in Madrid, the judges trust this, and then when they interpret what happened, it's more easy that they recognize it really, and then, for example, they calculate the damage, etc. It has a positive impact. This didn't happen in Barcelona, but now what we are organizing is just a learning activity between forensic doctors that that are going to start these reports with their unit, because they have been working with this. So these are only small examples of concrete development tools that we would like to develop or to have or to implement in the following months, just in order to avoid something that sometimes happens, and for researchers, and I'm a researcher, it's frustrating that you create things, you write very nice articles, reports, but nobody reads this, or it stays in the libraries. And here the main aim is to try to make something, not always, but something practical out from this. So therefore it's the only...
So the difference between Markus and me is like the women stays on my face. I'm talking to her, I'm trying to understand what's going on. And then the NGO is telling me, what's going on? Is she okay? I say, because she needs to testify next week. Can you prepare her? Can you imagine, you don't see my hospital, it's a huge hospital I have in the waiting room, I don't know how many there waiting. Say, no, this is something that has to be inside also of the protocol, like to prepare someone to testify. And especially if it's under stress or anxiety, it's very complicated. So the first step should be not to prepare the victims, to prepare the professionals, to make them understand this is not the time, or this is not the moment, or don't dismiss this case because it doesn't fit on your standards, because she doesn't fit nowhere, she's out of fit right now, talking on slang in general. So wait a little bit, that's what I would say, that's what I say for the forensic doctor, wait a little bit. He told me I cannot wait, the judge is asking me now, my report. I said, okay, we're fucked up both. So I'm telling you, she's really in bad position right now. You're in a bad position because you are supposed to do the report right now, and it's not gonna help her. Because at the end you say, no, the testimonio, the testify, I don't know in English.
Statement.
The statement is inconciso.
It's not precise enough, so it's...
I say, come on. So and you see the patient, she's completely dissociated. Like she's, I'm giving you an example. Like she's behaving like she's 6-year-old. Like she's going through really bad on regression, it's called. You know, and then not sleeping and not speaking and not talking. So it's not talking to the forensic and it's not gonna talk to the judge. She's not even talking to me. So why don't we wait a little bit, all of us? So I'm not in the judicial system. But in medicine, like things have to, well, they have the rhythm. So maybe we can meet the rhythms. That's what I would like.
Although it's very difficult.
Complicated. Thank you very much. So we would like to continue with a small panel because, of course, we have those working with the victims. They know about, or at least, I mean, it was, of course, most interesting what you found out. But you know, some of them they work with it, and we can hear about the problems and what needs to be done and can be done. So please, Evelyn, please, Federica and Patrick, and it will also be Norbert. He just had to do something for 10 minutes. He will be back in a minute. Yeah. So. You face this problem? Is this what is different? I mean, of course, we all know, you know, let me just say, we are not naive. We know that there is a lot to do between let's say, the criminal part and also the health part, because only recently we started, you know, oh, hi, okay, it doesn't work. Only recently we started to do a little bit more, you know, and to go beyond simply emergency, etc., etc. So this we are aware, but nevertheless, we would like to hear what the problems in practice are. Please, Evelyn.
Thank you, Helga. Thank you for your really vivid and emotional presentation of your research. And I'm very looking forward to get the results, because me and my background is I'm a psychologist and I'm now working since 20 years in the field, and I've been a direct counselor for trafficked women and girls for 10 years. Now not the last 10 years, not anymore. And actually, this is the problems what we are facing since ever. That to transfer our knowledge as NGOs and also our knowledge as a feminist migrants' rights organization into the system, that it's then accepted. Like we did a review, a legal review on the legal article on trafficking in 2013, and we were demanding that there is an obligation to get an expert to get a forensic expert testimony as part of measuring the result of trafficking. It didn't work out. So it means in Austria, we can plead them that please get a report, but they don't ask for it because they don't have to ask for it. A prosecutor, a prosecutor does only what they have to do legally. Legally for trafficking, it's not needed, so therefore they don't have to ask for it. And so it means that if you want to get a forensic statement, expert statement, you have to pay it as an NGO yourself. What we are doing is that we are doing it ourselves sometimes, because we are psychologists. So we are a recognized victim support organization, and we try to do a statement on that to use it for the case. We try to convince on the range of working with the police to tell them, you know, it's not time now. No, not today. She needs time, and you will not get a testimony because she still is not in a stable position to answer these questions. But I said, but legally we have to, because the perpetrator is in jail. We have to prove it as soon as possible to leave them out or not. So this is the range of the field, and we are doing trainings now for the police and for the judiciary, me and my colleague being psychologists, trying to make them understand what is fear, what is trauma, etc., etc. So this is part of the things what we are doing. And I think I have the feeling that a little bit of the part of the judiciary in Austria after 15, 20 years working in that understood it. We will publicize a book in 2 weeks where we also included this part for legal practitioners. But it's still, yes, we know we have to convince the system to accept it, but at the same time, we also have to be aware of that when we are working with the trafficked women and we are like also not talking about victims, and the recognition of a victim in the criminal field is very important, but to have it as part of a criminal investigation and not to label a woman as a victim for her lifetime, this is very important. We also have to be aware of that, or what we know is that whenever life situation got secured, means she has a certain control about her future. She can act on her own to plan the future living. All the symptoms, especially with that what you framed as anxiety symptoms, are reduced. And that's practically is residence permit. And it's having access to the society. I imagine two faces of two women what we had been supporting for a long time. One of them had been waiting for 3 years to get a secure status. She was in a big depression before, so it was really visible. It was visible that she can't do anything. She got the residence permit and it changed from the first day or the day afterwards. And all the symptoms, what we could have classified as depression and anxiety, was the loss of the control of her own life. That doesn't mean that it's very important to get access to therapy, to get access to help, in a sense, to restore all these effects of trafficking and the life before. But again and again, we have lived experience without a security about continuation of life. It doesn't help at all. And therefore, it's also like, obviously, and if you're now looking at the gender perspective of what we are talking about, now you have done a research on women, and we are working with women and girls. And if we know the figures from all over the world, is that at least every fourth woman has lived sexual violence. It doesn't matter if she had been trafficked or not. And I can't, if I would ask now every woman here when she remembers the first aggression on a sexual level, what she had lived on, usually it was on the 14, 15, being like in a rare situation with somebody who like attracted her sexually somewhere. So this is what we know, that this is experience of women all over the world. This is the experience the women we are working with, and they also know already now how to, they have learned certain patterns, how to live with it. And then it depends on if this is coping mechanism, which are positive coping mechanism, where we can really see them in our daily counseling work and support them to get more out of it, or if it's negative coping mechanism, where we have to take a look on if we can change them to positive ones. And our experience in our daily life with counseling the women, and also part of the shelter life, is that it's very often also the dynamic of the groups, the group which is living together, and how they can be supportive with each other. And it's established, it's possible via a mix of stabilizing the life, means giving back the control, and a psychological support.
Thank you very much. Could we continue, and you tell us a little bit how you, how your experience really in this field?
Yeah, thank you, Helga. Thank you for inviting us. My name is Patrick. I'm Patrick Hauvuy. I'm coming from France, and I'm with Federica Marengo.
Yes, I'm the coordinator of a national network for protecting victims of trafficking.
Just a few words. As I understood yesterday evening, exactly, we have the same English teacher with Norbert. So we're going to do
something, yeah.
a special duet with Federica, kind of Italian and French duet to present our work. Right?
Just to explain for the others, because especially Norbert, he uses always the present, I said, oh, please, just once, you use the past so that we know if it was or if it is or whatever, so this was the joke, so.
Thank you. So our association, ALC, is based in Nice, France, and we are specialized in identification, assistance, and protection of victims of trafficking. In 2001, we create, and since that date, we coordinate the French national network to protect victims of trafficking, so-called Dispositif Ac.Sé. The Dispositif Ac.Sé gathers specialized NGO, around 70 partners, and shelters, and we propose safe house and global assistance to victims of trafficking locally in danger and needing a relocalization far from the place of exploitation. Cooperation with the law enforcement is not a condition for the protection we provide. Victims of trafficking can be protected alone or with their children. As we're not psychologists, we would like to share with you some consideration concerning the causes of the psychological vulnerability we have identified in the VOT we protect, and a few initiatives and practices which are developed in France among partners of our national network.
Yes, of course. As Markus and Mar explained to us just before, the psychological impact is not just related to exploitation period. According to what victims of trafficking we protect told us, they are migrants also. So the psychological vulnerability is linked to the migration experience. They left their families back home. They experienced the exile. They have experienced the exile. They have a shock, cultural shock, because they have had an image of a destination country which is not the real life and the real experience. And so all these aspects can have an impact on them, and also they are migrants. They are stigmatized as migrants. They are stigmatized as prostitutes or as illegal workers. So these are all aspects that increase their vulnerability.
Concerning the specific case of Nigerian women, they arrive in Europe through the smuggling routes. They can suffer from PTSD because of the traumatic events during their journey to Europe. The Nigerian women we protect in our shelter explain to us that they are victims of violence, as you say, Mar, rapes, exploitation, before arriving also in Europe, as also IOM and UNICEF report in the study, Roaring Journeys. Like other migrants who take the Mediterranean route, they were confronted with death when they crossed the sea, and this specific step to their journey can be a source of trauma. But trauma can also be related to the context of recruitment and the departure through juju ceremony, for example, for Nigerian victims of trafficking, or under the psychological control of the madam. The belief and the fear in the juju can increase the traumatic symptoms. As a simple headache or a stomach pain or a nightmare can be related to the juju and can increase the power of the madam on them.
And then they can have impact also from the administrative situation. They are victims of sort of administrative violence, like Dublin procedures. They cannot understand what happens to them, and this is increase the psychological impact. And also because they have to tell their stories to social workers, to police, to asylum officers, and all this narration can make them vulnerable. So we are totally agree with you when you talk about complex impact, complex PTSD, and yeah.
The fact that victims of trafficking are vulnerable doesn't mean that they can act. It doesn't mean that they can make choice also. But of course, the trauma has an impact on the behavior of victim of trafficking. We call that the ricochet trauma. It's understanding in English, ricochet?
Not really.
Not really, ricochet. Yeah. That's it, ricochet.
Okay.
Thank you. But of course, trouble of memory, anxiety, as you decline also, inability to have coherent words are just an example of the consequence of this trauma. The partnership we have developed with specialized psychologists and NGO in Europe working on that specific issue allowed us to understand these consequences and to adapt our practices to improve the support we provide to victims of trafficking.
And when victims of trafficking come in our shelters, they must meet psychologists almost once. The psychologist explain to them who he or she is and the kind of job. But according to our experience, most of the victims refuse to continue to see the psychologist because they are afraid, because there is a stigma about, of course. So the psychologists of our shelters try to invent new strategies, new practices. They propose common activities like gardening or poetry workshops or art therapy in order to be in contact with them.
We also have a Nigerian intercultural mediator. We can also help women to understand how the psychological support is important and useful for them. The cultural mediator, she better understand the specific vulnerability and fears of the woman. She can reassure them, and in parallel, she explained the situation of Nigerian women to the social worker. You know, it's like an ambassador. She's doing the work in the two directions. She creates a link between woman and social worker. The intercultural mediator can be solicited by phone, Skype, and all the things, and she intervenes for all the victims of trafficking protected in our network. As another example of different way to approach the psychological issue, one of our partner in Paris, who works also with minors, victims of trafficking, implement a special program. The psychologist doesn't have many offices. She moves all around France to meet minors exploited in Paris and protected in different shelters. Psychologists' mission are in this specific case between those of the social worker and those of the psychologist. She informed minors about their rights. She answered their question, and of course, she listened to the minors and tried to create a truth and relationship. She also trained and informed the social worker of the child shelter on the issue of trafficking and the consequence on the victim of trafficking.
And of course, and we end then the we try to the psychological support is inside in a global support we provide to victims of trafficking, just not psychological, but also administrative, social, legal, health support. And we provide support not just because she or he is victims of trafficking, but because he's a person, a human being. So we try to have an holistic comprehension of the person and help him or her to become a person, a human being, and not just victims of trafficking, a survivor, like you said. Thank you.
But this, of course, it's necessary also that this is being paid, you know, that you have the resources, you know, do that, because in many countries this is sometimes the
Of course, we have the chance to we have resources, and when in the not in every shelters we have psychologists, so sometimes we have to try to find psychologists outside the shelters, and there is also the problem that in the big cities we have psychologists, and we have psychologists speaking in English, but when we protect victims of trafficking in shelters in the little cities, in the mountains, there are no psychologists, and sometimes they don't speak English, so it's very difficult to establish this support. Yeah, also for health support is quite difficult. Yeah.
Okay, thank you. Let's hear Norbert. What's your experience?
I have a totally special experience now, you know, because former I was responsible for children and minors who were unaccompanied in Vienna, and or come to Vienna without a really target, and for stealing and begging and shoplifting and so on, you know. So we make a program, and after I go in pension, and I go to Bulgaria, and I was asked to make a shelter for victims of trafficking. Now I'm responsible for returned people who comes from different countries from Europe, catched by the police, and sometimes they was in front of the court or not, you know, immediately returned without papers, without any reports, and without any results for us. So I can say 5 of these girls who I get back who are victims of trafficking from the court. The court says they are victims of trafficking, and they are now returned. Everything is closed in the foreign country. Now we have to make research about what happens in the country, why they go there. And what I see and what I feel now is it's a very different to my old work. It is 90% of these women are sick in special ways, not just in the psychological way or in. We need psychiatry. For 80% of the women, we need a psychiatric help. We need to go there, and we need to help them in a way that they calm down, that they give away the traumatic symptoms. You know, they scratch themselves, they cannot sleep, they jump up, and they are like a lot of different symptoms they have. You know. So this is absolutely new, was new for me, you know, and yeah. What what is the target from us is that we try to calm down the situation. We try to integrate them in the normal society. We try to give them a target. And we try to find what they want. Because they don't know what they want. They lose a target. They lose the line of the life. They are struggling what's, in general, what's going on with me in general. I have nobody. Nobody helps me. Now, this is my home country. And yes, I cannot go home because near to my home, the perpetrator and the friend of the perpetrator and the friend of the friend of the perpetrator will catch me again. They know this. And they are afraid of this. And therefore, they don't want to go back in the family. They don't want to go back near where they have relevance. And it is hard for us because all of them, for example, all of them have a sickness. One's come back with syphilis stadium 3, with fungus all over the body. And she comes from Sweden, and we don't have a medical report. We don't get it. She just come back. We have to find out what happens. Now, it is, you know, Bulgaria, this is not a so rich country, but we get money for to do it. But after we find out, okay, she needs a surgery, she needs a special help, because the syphilis in stadium 3, it is very heavy, you know. She get black marks on the body all over, like this, big like this. She have black marks all over. She get this in the, and we are very shocked, and we send them in the send her in the hospital, and the doctor says to us, this is normal. We are, but we have other girls or women in the shelter too. So this we have to take care of them, you know, to everybody. This is very difficult, and yeah, we get support from the municipality. We have a lot of support from the hospital, also from the psychologist and from the psychiatric clinic, but sometimes it is like I'm on the plafond, you know. I don't know what we can do, because.
May I just ask, it is on the voluntary basis, this cooperation, or is there an official structure that you can address?
Half-half, half-half, you know, because you must know that when they go outside of Bulgaria, they do not pay the health insurance. When they have no health insurance in Bulgaria, no doctor help them.
Yeah, no? This was my question, because in many countries, of course, it's like
no doctor help them. So we have a cooperation with IOM, and IOM have a program with the Swiss that they have money for to pay the health insurance, you know, for maybe 1 year, when they was out 1 year. So IOM Bulgaria pays for 1 year the health insurance. But after, we have to pay this, you know, just for the time what is lost, you know.
We, meaning the shelter,
your shelter. Yeah. After, the shelter must do this, and we don't have the budget for this, you know. So I have to ask people who give me money, can you give me money? Yeah, and this is very hard sometimes. And my special, you know, my special woman who is beaten so hard that she nearly died.
Actually, she was beaten, you know.
She was beaten, yeah, sorry. She was beaten so heavily, you know, that she nearly died. And the hospital says, okay, we make the emergency support, but after you must take her. And I have her in the bed, in a room. She cannot stand up. We must give her all support to help her to get up, to go to toilet, you know. She was cutted and sticked and unbelievable, you know. And IOM pays after the health insurance. Then we can give her again in the hospital for 1 week because she have a, I don't know, Darmverschluss.
I don't know either. Something, huh? No.
Yeah.
Yeah.
But
Yeah.
it means that we have to look what was in the past. We must make a history about this, what they had in the past, you know, and how we can give them a future, and we can make a plan together with the victim. We must make a plan together, step by step, to go in the right way in the future. This is very important that you make a plan who is to realize, and not just a fictive plan, you know. We must give them a really touchable target.
Yeah. Okay, but what we see, if I may just summarize it a little bit, I mean, in most of the countries, I mean, we have something, you know, so over the years, you know, they understood, there is something, you know, with health, I would say something, you know, not in some countries, they understand a bit more, we have already started, or in some countries, they have started to establish a structure, like in France, you know, so that's there, really, I mean, it's also the question if this is enough or whatever, you know. In other countries, I mean, we had the situation where there was nothing, where there were only NGOs, you know, really, or the NGO in Austria supporting the victims and lobbying for the understanding, you know, what is going on a little bit. So now it's a bit better. It's not, I mean, can be done much more. And as we see in Bulgaria, let's see, it's all on the initiative of somebody, and unfortunately he is so creative and tries to get some funding, and nowadays anyways what governments sometimes, I must say, you know, prefer, you know, to do some charity, you know, to donate for something, a bit of money for something, instead of establishing a real structure, which then finally could work, you know, because what you said, you need a structure, you know, so it's not just a moment here, a moment there. No, it should be a real structure. So, but I would like to give you the floor, you know, to maybe, if you wish to add. Is it gone? You have only one micro that works?
It's okay. No, I'm just, because of my regular practice, one tip that works super good with the Nigerian women is just to remind them that unfortunately in Nigeria there is one psychiatrist for every 9 million people. So this is the whole data. So when I tell them, when you break the first barriers, the cultural barrier, like no psychiatrist, I'm fine, no. When they come to the hospital, for example, the first work has been done in the NGO, like preparing, say, no, just go and see the doctor, she will help you. So we're trying to work on that. They don't lie to them, so you're going to see a doctor. will say, you're going to see this doctor, she's a psychiatrist, even if they don't know what it means, or they have a lot of stigma. So once they are there and they do the setting is a huge hospital, I'm any other specialist, I'm just there. So most of the time I just tell them and remind them this, like, you have this idea about psychiatry because in your country, really the situation is really bad. So if you just have one psychiatrist for every 9 million people, wonder who goes to the psychiatrist. So in psychiatry, we have different disorders, different problems, not problems, sicknesses. So this poor psychiatrist is going to be helping only in the really, really don't imagine. So when I tell them, you see here in Europe, we're a little bit more lucky. We have more proportion of psychiatrists, so we can really attend people with a really bad sickness, with mild ones, with light ones. So maybe I will be with you just for 2 or 3 months, and then you will never see me again. So this poor person that you are facing and you're reminding, this person, probably in Nigeria, has a really bad disorder, most of the time psychotic disorder, schizophrenia. So he will be forever attending this colleague. So like giving them the example, like in Spain, you don't have to be dying of a heart problem to be attended at the hospital. Yes, in Nigeria, maybe also. So you're lucky now, lucky. And you're in Spain, we do have universal system from now on, they didn't take it anywhere. So you can be attended for a mild, for a small one, for a big one, you will be for a short time, another one will be for a lifetime, because he has a problem of lifetime problem. Yours is not for lifetime. So usually this is a way of enhancing them, because they get very curious and say, oh, why is there only one psychiatrist for 9 million people? Okay, like many other things that they are not developed in the country. So this is just to reduce stigma and fear. Like, and also going to the somatic symptoms, it always works. If they don't sleep, day after day after day, in any culture, in anywhere in the world, everybody knows, if I don't sleep, I will get sick. They won't say mentally. They will say, my body will get sick, my soul will get sick. But the sleeping problem is really where you can always get in touch with them. Say, do you want help with this? So maybe it's the voodoo, maybe it's this, maybe it's whatever. But we can have a way to help it out. And sleeping and eating. Losing weight and not sleeping, it's all around the world. Any culture, any ethnic group will get afraid about this. So maybe we don't start with the direct, you go and see a psychiatrist. No, we say, let's see if we can help in this issue. And if we have the resources, because in Spain we don't have them. We don't have psychologists in the NGOs. We don't have them. So we need to use the public network, the psychiatric mental health, and it's complicated. In Bulgaria, they don't have national system, health. So we have different, every country is different.
In addition, we must say that we would also have to, this means that victims must have the possibility to stay, there are no quick fixes, and what you tell us, if they are expelled immediately, or if the minimum time they let them stay, is a couple of weeks or whatever, this is not enough, then you cannot do anything. And I would also think that sometimes authorities are reluctant to do something on the health issue because they just try to get rid of these people as quickly as possible because it doesn't cost, then it's the problem of others. Evelyn.
I really would like to add to that, or also to put together what we have been listening. Yes, of course, there is the psychological need of support. Very important. We start from the first moment on, and we have the luxurious situation that we are also psychologists, but we have the concept of psychosocial support, and we know that before we can start any other measure, we have the concept of crisis intervention, that you firstly have to stop the crisis, and then you can work things on to really continue then to work on psychological symptoms and also to work on psychiatric symptoms. So this is the work what we are doing, and then we try to establish close contact to psychotherapy or psychiatry whenever necessary. Yes, we have the system in place in Austria that now we can refer to psychiatric support which is here existing in Austria, which is important. But it's a little bit more difficult, and this is what you added, Helga. How can you offer this support to somebody who doesn't know if she will be deported in 2 weeks? So
no, but
this is not.
Sorry, no, that's a point, because in a Maslow pyramid.
It's not attacking you, but I think this is.
No, me neither. I'm attacking you. I'm just giving some, because I think in Spain, as
Maybe-
I'm hearing,
sorry,
we're
may I-
lucky because we have in the Maslow system, we have it covered. They're not expelled. They have national health system. Yeah, we may be lucky, or maybe Spanish were just gone. But those things are under control. They have a shelter, they have an ear, they have
I know the Spanish legal
So,
system. Sorry,
that's
I
why we can
wanted to
work.
finish a sentence in
Excuse
the sense of getting like to that what you said, in that when you were talking about these 2 victims who were repatriated from somewhere to Bulgaria, and we know one country is Sweden and the other one we don't know, they were violating European law. So, and this is what we are living then. We have systems in place, but they are not implemented. And we got referrals from Denmark, for example, to Austria, because it was not the proper place to stay. Spain is always at the beginning route, so that the situation is a little bit different. We had to repatriate victims to Spain. Also, there had been already in a comprehensive system of support here. So this is then the interlinkage. And what you said is that the violation of European law is that there's law in place, and it has to be in every country beside Denmark, because Denmark opted out and the UK opted out. So then we have these 2 countries where we cannot count on that there has to be a victim support fund where any effects of the crime, is it psychological or is it health effect, has to be restored by the state. So then now that you are looking for money somewhere to cover the minimum, is a violation of European rights, because Sweden should have paid for that. And the second country, I don't know if it's Denmark, sorry, then no. Yeah, but then, and this is what I'm getting so angry about, because there's the need, and this right is in place since the 70s, and then it depends on if it's if it's then adopted and if it's then adjusted to trafficking victims. In Austria, we had the situation that due to the irregular status of a person, the person was excluded from this right. It was changed. Now the right is for if it's a recognized victim of trafficking, but it depends then on the identification. But this is where I see that there is like the contradiction where we're living very often is the person as a right holder, where we were fighting for implementing these rights, versus the victim, which has to be supported, and where there is not sufficient knowledge about that, what the support is, what is needed on the support. And I think it's good. We are here to train. We are doing this as an NGO to train about this since years and years and years, and still we don't reach the church who says, yes, yes, I'll accept it. But we also don't reach the migration authority telling them this is a victim, because they say, no, she's lying because she wants to get rights, what is only supposed to be for a minority out of this big group, what Berber was also telling today, nobody cares about.
Yeah, we continue fighting. I'm sorry, I have to cut short our discussion because they will throw us out simply in a few minutes. So because the discussion is important, and as you said, you know, for so many years, you know, we are fighting for that, and still it's a problem, and everywhere we try to manage it somehow, you know, and to get somehow through, which is certainly not correct. But thank you very much. I mean, it was most interesting to listen to what you did on the project. There is, I think, a final conference in end of November. So those who are interested, we shall put it also at our website. Those who are interested are probably invited, you know, to join on their own cost, unfortunately, I must say. But nevertheless, this is what we could do to follow up. And who knows, you know, maybe you continue, you get a next step on the project, and we will move forward. I mean, we have been fighting for so long, so we have the energy to continue in doing this. So thank you very much to Markus. Thank you very much to you, Mar. Thank you to the panelists. And yeah. Thank you. And soon again, thank you.